And welcome to our webinar on PrEP in implementation learning. My name is Wawira Nyaga and I work with AVAC as the Director for Product Introduction and Access. And I will be chairing this session. Remember to click on the icon at the bottom of your screen to choose your preferred language. We have a couple of languages listed there. And please, if you have any questions, remember to use the Q&A box to ask questions to the panelists. But to start us off, we are delighted to have Professor Lloyd do the opening remarks and introductions. I am not sure whether Professor Lloyd has joined us.
I think Lucy's going to step in, Wawira.
Thank you so much. Lucy, over to you to do the introduction and the welcome remarks.
Yeah. So good afternoon, everyone. My name is Lucy Maikweki, and I'm with the South to South Learning Network. I'm the team leader for ARV-based prevention. And today we have quite a vibrant discussion. Allow me to keep my camera off because I have a low bandwidth so that I don't keep cutting. Yes, so today we have a very vibrant discussion around the lessons that we can learn from the implementation of PrEP. We have come a long way. HIV prevention has come a long way since the days of behavioral interventions to right now when we have biomedical prevention tools like PrEP. And ever since the introduction of oral PrEP, we have quite an array or a basket of products that countries can be able to use to scale up HIV prevention. But as we have this discussion, we want to ask ourselves several questions. What is the most effective prevention tool? What does combination prevention look like? And with the era of dwindling resources, what does combination prevention look like, and what tools can we use and for which populations? And so today we have that discussion. We are going to be learning quite a bit from the findings that AVAC had recently of getting PrEP rollout right, the lessons that they have learned. So this webinar is going to be sharing those findings. We're going to be sharing country-level evidence and insights. And we're also going to be introducing a standard operating procedure for lenacapavir as a tool and a resource for countries just to increase and to scale up the introduction of lenacapavir. So today we have several speakers. We have Catherine Hashim from AVAC. We have Hasina Subeda from South Africa, who's going to be giving us country insights together with Patricia Jekonaya from LVCT in Kenya. And we have Natasha Okapara from Pop Council Zambia, and Kamo, who will also be talking about effective interventions for PrEP adherence and support, and sharing an evidence review. Thereafter, we will have a question and answer session, and then we will be able to do some closing remarks where we will also be able to share the standard operating procedure for lenacapavir. So with those few opening remarks, I want to hand it over back to the chair.
Thank you so much, Lucy, for those beautiful opening remarks. And indeed, we are at a critical moment as a HIV prevention community. And we've seen in the last few years that PrEP has really become one of the most effective prevention tools in our global HIV response. And yet, despite its proven efficacy, uptake around the world has not kept pace with the urgency as per the UNAID 2030 targets. If you could just proceed with advance the slides, please. So as you can see from that slide, it's just a couple of slides. We've done generally well when it comes to PrEP initiations. By the end of last year, we had well over 8 million people initiated on PrEP, and we saw that growth really from 2021. But to the right, you can see that graph that shows how we are doing against the UNAID 2030 targets, and you can see we already missed the mark for 2025. But we still have 5 more years, and we are hoping that by 2030, given the prevention toolbox that has really expanded and the opportunities that we do have, we shall be able to make some traction. Next. I shall not belabor on this. Lucy talked about the tools that we have. And what we can see is we've really grown for the last 10 years. We've grown from oral PrEP and PEP to 2 monthly injectable CAB. And now we have, a monthly vaginal ring. And in the, near horizon, we have lenacapavir, the 6-month injectable, which many consider as a game changer. And we hope that countries, especially the 9 priority countries, will start rollout by early next year, if not this year at the end. And so we do appreciate in this meeting today, we have different people who are at different stages of implementing LEN. Some of you are preparing to launch your first ever PrEP program. Others are trying to figure out how to integrate CAB or DVR into their existing programs, while others are in a more complex situation whereby they'll be thinking how to layer on lenacapavir to already well-established services. And others are just in between. So what we want to say is wherever you are in your PrEP journey, the insights that we're going to be sharing today are designed to help you launch and scale up or even strengthen your PrEP program. Lucy already shared the presentations that we have lined up for you. So I'm not going to belabor that point, but I will kick it over to Kat from AVAC to share with us some of the learnings from the field that are drawn from AVAC's recent report that is getting rolled out right this time around, because we already squatted a few years ago. Over to you, Kat.
Thank you so much, Shawira. Next slide, please. Next slide. Great. Perfect. Thank you. So today I'm going to be sharing some key insights from our new report, Getting PrEP Rollout Right This Time. I'm going to start with some brief background on why we did the report and the methodology that we used. And then I'm going to take you through some key insights themed by stage along the product introduction pathway. And I'll explain what those insights mean for those who are getting ready to introduce LEN. Next slide, please. So just a brief note about the methodology that we used for our analysis. We started with a rapid desk review. We reviewed 59 scholarly articles, meeting reports, consultation summaries, etc. We interviewed 26 key informants from Ministry of Health officials, implementing partners, and civil society leaders. And we conducted all our data collection on the time period November 2024 through January 2025. And the reason I want to flag that is to show that all the data collection happened prior to the PEPFAR stop work order. So everything where all the insights here came out from a world prior to PEPFAR stop work orders. And then we undertook a qualitative analysis of our data. So if you look on the map on the right here, this is to show you the countries that were chosen for our key informant interviews. We chose them based on size and duration of their PrEP program with diverse geographic representation. This map here is a heat map of PrEP uptake by country, with the darker colors indicating higher PrEP uptake. So you can see the 7 countries we chose all had very high PrEP uptake, and these were Brazil, Nigeria, South Africa, Zimbabwe, Zambia, Kenya, and Vietnam. And I also want to say a huge thank you to our key informants. I think some of them are on the call. We really appreciate your time. Next slide, please. Great. So the first theme we're going to look at is regulatory approval and normative guidance. So we found through our analysis and research some important key insights. We found early engagement with ministries of health, regulators, and other stakeholders creates awareness of new products prior to regulatory review. We also found that approvals from other regulatory bodies, such as from the U.S. Food and Drug Administration or the European Medicines Agency and WHO pre-qualification, can help expedite national approvals. And we found that WHO guidelines can form the basis of national guidelines for new products, and advocates can help ensure guidelines are as inclusive as possible for all populations. So what does this mean for LEN introduction? We need to begin engaging stakeholders now. We need to leverage approvals by the US Food and Drug Administration and the positive opinion from the European Medicines Agency to support and expedite the regulatory review process, and look out for WHO pre-qualification. So just to note, the US Food and Drug Administration approval came in June, and we had the positive opinion from EMA last month. And we're expecting WHO pre-qualification in September or possibly even as early as this month. Now is the time to begin forming PrEP technical working groups to adapt the WHO's LEN for PrEP guidelines, which were released last month at the IAS conference, International Guidelines. And we need to ensure these guidelines are as inclusive as possible. And the latest data we saw from the LEN trials, which was shared at IAS, shows that LEN is safe and effective for adolescents and pregnant and lactating people, and guidelines must reflect this. And I'm just going to put some links in the chat that relate to what I've just been speaking about here if you'd like more information. Next slide, please. So looking at some planning and budgeting insights, we found important considerations in deciding which PrEP products introduced were effectiveness, as seen in clinical trials, price and cost effectiveness, including knowing what the price will be without donor subsidy and when generics become available, and sustainability of supply and confidence a product will be available long term. We also found that budgeting needs to include costs for awareness campaigns, demand generation, updated monitoring and evaluation systems, preparing the public health system, and provider training. And this is going to be a common theme across all the slides you're going to see. Budgeting for PrEP rollout does not just mean service delivery. We need to include all the components of rollout, just the ones mentioned here. So what does this all mean for LEN introduction? First, we need to advocate for pricing transparency to allow ministries of health to plan accordingly, with the expectation that generics will become available in 2027, and these will be much less expensive. Right now, countries need to be considering what choice means in your local context, and does this include multiple injectables? So for example, if you're a country that's already rolled out CAB for PrEP, are you going to add LEN for PrEP? Are you going to switch to LEN to PrEP exclusively? And what does this mean for users currently using CAB? We also advise consulting the latest evidence on preference for injectables, data on product switching, evidence from PURPOSE trial results, and recently released need estimates for key population need for PrEP to help with demand forecasting. And to now plan for how to fund procurement post-donor funding. So some things you can consider. We all know that donor funding is reducing. It's not going to be around forever. So some alternatives to consider include taxpayer levies, national health insurance schemes, and exploring private sector, including pharmacy models that include user cost sharing. I'm just going to put some key links in the chat, which are also in the slide here. Next slide, please. Great. So next, looking at stakeholder engagement, what were some of the key things we found through our research? First, communities are not being kept up to date on pressing issues around new products, and this leads to low levels of awareness and engagement, particularly amongst youth. We found that constant and early active engagement with civil society organizations is essential, as is direct engagement with young people and key populations. In addition, the private sector needs to be engaged early to ensure buy-in to PrEP delivery. We can't expect them to just start delivering PrEP. And of course, again, as I mentioned earlier, stakeholder engagement, like many of these other things, requires budget allocation. So important considerations for LEN for PrEP introduction in light of these findings. Anyone introducing LEN should start engaging communities and civil society organizations now on LEN for PrEP if you have not already, and do not forget to include youth and key populations. Now is also the time to start engaging the private sector, including pharmacies, to explain and promote the value proposition of LEN for PrEP and ensure providers are ready and motivated to offer it once it becomes available. Now's the time to explain things like how PrEP can bring in new clients, how you can cross-sell, and really make the business case to private providers about why LEN is important. And I want to note that the Coalition to Accelerate Access to Long-Acting PrEP is fostering coordination amongst a wide range of stakeholders, including through a community of practice with early LEN adopter countries. And I'm just putting a link in the chat where you can find updates to what is going on with the coalition and how we are coordinating stakeholders. Next slide, please. So next, we look at demand generation. So some of the key insights we found in our report. First, collaborating with civil society organizations on demand generation materials and campaigns can ensure these are non-stigmatizing, which would be very important. National campaigns with status-neutral messaging are perceived as the most successful. We also found that, again, like everything else, campaigns need to be properly funded and to have consistent, up-to-date aligned messaging to be successful. And we found that demand generation partially takes place through healthcare workers. This is a form of demand generation that really is closest to the client and closest to delivery. So healthcare workers need to be trained to lead literacy and awareness sessions in health facilities. So what does this all mean? What are the implications for LEN introduction? First, that ministries of health need to begin developing status-neutral LEN messaging and campaigns now, alongside information, education, and communication materials, ensuring to co-create content with communities. Governments introducing LEN should consider using innovative approaches such as digital platforms, peer-led models, and integrating messaging into popular media, because we have seen success with this for other products. Now is also time to begin training providers to deliver key messages on LEN awareness, and keep in mind that provider training is not just about clinical training, but also about how to deliver these messages. And again, ensuring sufficient budget, like with everything else for demand generation, is very important. Next slide, please. Next, we come to supply chain management. So some key insights around supply chain management that we found through our report. First, you can leverage existing ARV supply chains when introducing new products to help with efficiency, rather than trying to start up new supply chains. We also found that urban areas are often prioritized for new product introduction, but this widens health disparities with rural areas, and a more equitable approach is inclusive of underserved areas. So just a reminder to not just go for low-hanging fruit, like very densely populated urban areas. We have to keep in mind that there are people with PrEP needs in all types of areas, rural areas, that are last mile clients, and we need to ensure that we cater to them as well. Sites should be addressed for readiness prior to site selection for new product introduction. And we found that some countries, to manage risk of stockouts impacting continuity of care, were adopting measures such as adjusting testing algorithms during testing stockouts, so perhaps reducing the testing frequency required, or allowing multi-month PrEP dispensation. So what do these insights mean for lenacapavir for PrEP introduction? First, we should plan to integrate LEN procurement into existing supply chains. Secondly, remember to prioritize equitable LEN access, including those rural, underserved, and last mile communities, and this can often be done via community distribution. And finally, to begin infrastructure assessments of sites selected to offer LEN for PrEP now to ensure the facilities meet requirements. Next slide, please. Now looking at some of our insights from health service delivery. Some important things we found. First, that a lack of counseling in many facilities is leading to early discontinuation. This is a really important point about counseling quality, especially now that we're in an era of PrEP choice. It's really important that providers are successfully able to help clients, to navigate clients to the product that will work best for them and fit with their lifestyle. They'll be much more likely to continue using it that way. We also found that PrEP uptake is higher when integrated into other sexual health services, such as STI services or family planning. So important to consider integration. It actually does improve PrEP uptake. We found that innovative and demedicalized approaches can improve access, and this could be everything from pharmacy delivery to delivery via vending machines, delivery within the community. We found these are very helpful. And we also found that early sensitization and training with providers, including private providers, is key to ensure enthusiasm and readiness. And finally, that task shifting can free up provider time for more complex services and improve PrEP access. And what we mean by task shifting here is training lower level cadres, such as pharmacists or community health workers, to deliver PrEP, thus freeing up time of other providers, such as nurses, to handle other services. And this also greatly improves access, as there are a lot more of these lower level providers than there are of higher level providers. So what does this all mean? What does it imply for LEN introduction? First, we suggest exploring differentiated and demedicalized service delivery models for LEN, such as via pharmacies, mobile sites, or community-based delivery, and to review what policy changes may be needed to facilitate this. So for example, in your country, perhaps pharmacists are not allowed to prescribe PrEP. So look at changing some of those policies to increase access. We also recommend that now is the time to begin sensitizing and train providers. Some proven strategies include exploring training of trainer models and also using virtual models, and considering a phased approach starting with providers already delivering PrEP. We recommend using WHO and JPIGO's new provider training toolkit to support this process, and I'm just putting a link to that in the chat right now. It's now also the time to begin developing and adapting tools for choice counseling to include LEN as an additional PrEP option. And I wanted to ensure everyone was aware that the WHO guidelines released last month at IAS recommend rapid diagnostic testing for initiation and continuation of LEN. So this should be taken into account when countries design their own delivery models, that we do not need to rely on more expensive lab-based testing. Next slide, please. And finally, research, monitoring, and evaluation. Some key insights, we found it was very helpful to look at data when deciding where to roll out new products, such as geographically, so based on population density or HIV incidence data, but again, not forgetting those last mile or harder to reach clients. Looking at populations, such as focusing on key populations, or being impact driven, so looking specifically at facilities with current high numbers of PrEP users when deciding where to introduce new products. We also found it important to review indicators to assess readiness for new product rollout. For example, if facilities are already delivering to a lot of clients, a lot of PrEP clients, that would be a good place to introduce a new product. And then robust centralized health data systems can support accurate measurement of PrEP products and other commodities in the supply chain. So some considerations for LEN introduction. First, leverage existing data in deciding where to roll out LEN. And now is also the time for ministries of health to begin updating their monitoring and evaluation systems to include LEN. And we recommend considering including the following indicators. This includes PrEP uptake by product age and population, amount of PrEP dispensed by method, reasons for switching and or discontinuation, and number of people with an HIV positive test result while on PrEP by method. Also note that LEN should be included as part of any minimum prevention package as being developed by ministries of health. Next slide, please. So some key takeaways. These are things that we really found are keys to success when scaling up PrEP or introducing a new product to keep in mind. First, address gaps in your health system to prepare for efficient product introduction. Plan and discuss financial sustainability. Proactively educate yourself and other stakeholders about the benefits of PrEP, including new products. Collaborate with civil society organizations and actively reduce stigma associated with PrEP and package messaging and counseling based on end user preferences. Make healthcare provider needs, including comprehensive training and training beyond just clinical training, a top priority. Use data to drive PrEP rollout. And leverage existing product procurement and distribution systems and update your monitoring and evaluation systems or electronic medical records. Some important challenges to keep in mind as you scale up your PrEP program or introduce new products. We found that regulatory approval processes can be mired in inefficiencies as well as policymakers' personal value systems, and this can delay approval of products. There are challenges around lack of transparency for manufacturers, delays in the product supply chain, and potential lack of donor support. We also found insufficient engagement with the private sector and youth and budget allocations for engagement not being prioritized. We also found insufficient funds for demand generation, as well as limited provider capacitation on counseling and inadequate product supply. A huge challenge is unequal societal distribution of PrEP, as we mentioned, and infrastructure challenges which hinder holistic population-led service delivery. And a very big one is existing human resource and commodity constraints. So that's everything. I'm going to put some links here in the chat for some additional, for the entire report, if you'd like to read it, some specific considerations for LEN, as well as links to prepwatch.org, where you can find all the most important resources and tools to help with your PrEP rollout, whether you're just starting up your PrEP program or you're expanding it to include LEN. And thank you very much. I'd like to hand back to Elvira. Thanks.
Thank you so much, Kat, for those great insights, which I must say are very timely, especially in a time when, the 9 countries are thinking about planning for land introduction. And now we're going to take a deep dive into how the experiences from the countries in terms of introduction of CAP and DVR, and how the countries are preparing for land introduction. And to take us through that, we have 2 countries, South Africa and Kenya, and we will start with Hasina from South Africa. Welcome, Hasina.
Good afternoon, Warira. Sorry, my camera doesn't want to come on. Okay. Good afternoon, everybody. And it's a privilege to be joining you today to share some of our South Africa's journey in implementing PrEP since 2016. And we have learned quite a lot of lessons during this period, and we would like to share some of those insights with you today. Can we move to the next slide? Am I sharing my own slides? Okay. So as we look at where South Africa is with South Africa's epidemic, South Africa remains at the epicenter of the HIV epidemic. We have 7.6 million people who are living with HIV. We have 160,000 new HIV infections and equating to 400 infections a day. We have 45,000 AIDS-related deaths. And if you look at the variation in terms of HIV prevalence in the general population as well as the key populations, it is quite varied. I think these figures remind us that HIV prevention is not optional. It's urgent. Every infection we prevent today saves a lifetime of treatment and preserves a life. So let's prioritize HIV prevention. Let's move to the next slide. And this is what we did in the country, in South Africa. Since 2016, we started implementing oral PrEP in a very limited way at the beginning, and expanded. By 2020, we expanded across into our public primary healthcare facilities. As we speak right now, we have over 1.9 million people that have been initiated on PrEP. 97% of our public primary healthcare facilities are currently offering PrEP, and over 4,350 service delivery locations across the country. In 2024 alone, we had over 450 new users that were introduced to PrEP. So the key to South Africa's success was that PrEP was embedded and integrated into our primary healthcare service. Next slide. What was really important when we scaled up oral PrEP was we used a data-driven approach where we looked at the catchment population of every single primary healthcare clinic. We used the HIV prevalence and HIV incidence rates, and based on that, we looked at who should we be reaching with oral PrEP. But before we start with oral PrEP, the important thing is, who do we create demand for HIV prevention, amongst which populations, which geographic areas, which age and gender disaggregation as well. And this really informed how we scaled up oral PrEP. And if we move to the next slide, if you look at the implications of having that data-driven approach, one of the things that we did with oral PrEP is we prioritized the high burden districts using district level HIV incidence data to guide oral PrEP, and we will now use it to guide LEN rollout as well. Maximize impact and cost effectiveness by focusing, and we do know that we have limited initial supplies, and we need to look at where will we be getting the greatest benefit from implementing LEN, especially where there is the greatest need. Special targeting is also really important in making sure that we focus and don't dilute our stock in low priority areas, but we focus on those where we have high volumes, high density, and perhaps as we have more stock available and more commodity commodities available to then expand everywhere. Concentrate our efforts in high incidence districts to boost demand creation, use disaggregated targets by population group, age, gender, and to align services with our epidemiological risk profiles, and also to ensure equity by giving those at highest risk earlier access to LEN, tailor our demand creation, messaging for specific audiences, implementing differentiated models such as youth-friendly clinics, or especially where we have remote areas that we need to reach, and making sure that mobiles are available to reach those populations. But most importantly, using our disaggregated approach to monitor and track uptake as well. Next slide. So the early insights from the implementation science studies, and the country had approximately 87 sites where we have been implementing oral PrEP, ring, and CAB-LA injections. And these implementation sites provided us with very useful insights. We saw PrEP uptake was notably higher at sites where all 3 PrEP options were available compared to sites where only 1 or 2 options were available. So it was quite clear that where choice was available, people were more open to accessing PrEP in those sites. National guidelines, job aids, social mobilization efforts, and reporting tools also ensured that we had standardized delivery, messaging, and reporting. And as we move, into LEN, we will use the same approach, making sure that at every single point that we implement LEN, we have it's guided by the national guidelines and a standard set of tools. Uptake of injectable PrEP was high, the highest amongst the age group 20 to 34 and females. We also saw that it was practical to implement an injectable in primary healthcare clinics and mobiles with no major logistical challenges relating to transportation or storage. So persistence rates was also very high, especially amongst those that utilized the injectable. And we saw at least 75 to 77 individuals coming back for their CAB injections at month 1, compared to 39% amongst the oral PrEP users, and by month 3, 62% to 41% came back for the injectable compared to 33% on oral PrEP. And I think this has been, important for us to take note of, because definitely people on injectables are more persistent. Move to the next slide. So one of the critical elements, and I think it was also stressed by Catherine, is that if we don't plan for having commodities available, we will have challenges with rolling out any new product. And we saw this with both CAB and the vaginal ring. It took us 16 months from regulatory approval to where we started the first sites with the vaginal ring, and 14 months with cabotegravir. And this was largely because of supply constraints, and the supply constraints were from the providers, the supply routes into the country in terms of making sure that those products can come and be imported, the importation testing that needed to be done, and then made available at facilities. So this is really important. As we move forward to LEN, we must learn from this and make sure that these are addressed upfront, shortly before regulatory approval, but shortly after regulatory approval. We can move to the next slide. So our key recommendations for scale-up of injectable PrEP is training of healthcare providers should cover all available PrEP and HIV prevention products. And this is important because we do not want our healthcare providers to lean towards the newest PrEP product, but make sure that all available PrEP products are offered equally to our healthcare users. Additional support and guidance required for injection techniques, injection pain management, and managing injection site reactions. And this is important, especially for LEN. It's a slightly different technique that's being used, and we need to make sure that, injection pain and injection site reactions don't become a hindrance. And we want our healthcare providers to manage that adequately, and then to support clients to return on time for follow-up visits, simplified choice counseling, transitioning to other PrEP and HIV prevention methods should be made easy. Bridging doses and injection scheduling for mobile populations needs to be addressed. Stopping injectable PrEP and monitoring HIV status during the tail period requires close monitoring and drug-drug interactions. HIV testing schedules, especially testing requirements and frequency of testing, especially for long-acting injectables, we need to make sure that we balance the need for testing, but also we don't make it difficult for individuals to come in for repeated tests as well. And then generating evidence for use of self-test screening and for long-acting injectables. And this is required, especially if we want to look at simplifying delivery as we move forward. So these are some of the key learnings that we want to share with you today. And I do think as we move along and as we start implementing the long-acting injectables, we'll have many more insights from that. So what's important is that when people have choice, access, and support, they use prevention. When health systems are prepared and products succeed, we will see good uptake of these new products. When we work together, government, civil society, and communities, and develop partners, we can not only introduce new PrEP, but ensure that we reach those who need them most without delay. So let's make our lenacapavir journey from approval to access the fastest, because every day matters. Thank you very much.
Thank you so much, Hasina. Great insights from South Africa. Taking choice, access, and availability will get us there. But I do recognize that Professor Lloyd Mulenga from Zambia, that was supposed to give us opening remarks, has joined the meeting, and would like to give him a minute to just say something before we proceed to Patricia. Professor Lloyd.
Thank you, Awira, and excuse me for the hoarse voice, not feeling too well. Indeed, this is an exciting session, and when you look at where we are coming from for the countries which have been implementing PrEP, especially for CAB, you see that there are certain things which went wrong the way we started, and I don't think we need to repeat these. We need to be very sure that we broaden the clients whom we are going to reach. Earlier on, when we got CAB, we limited ourselves to certain subpopulations, but also many countries would say that there are a number of people that do not self-identify with certain risk categories or risk groups. So as countries, we need to avoid that. Then also, we need to make sure that we invest heavily in demand generation. This is something that we've struggled with. For Zambia, this is when we just passed the 4,000 mark of those that we've initiated, and we have been implementing this now for more than 16 months. Other areas which I think are also important as we consider this is to look at how ready are we, the regulatory processes, which were a barrier in many areas, and this has been highlighted by Hasina as well. We need to make sure that we don't repeat those aspects. I think for governments, it's important that we are ready. We need to have roadmaps that are speaking to the needs, but also we need to make sure that the community is heavily engaged and make sure that we do not just, again, concentrate on one option. We need to provide the choice. And there is a danger that as countries, we may just think that maybe lane is the only answer. But what we have learned is that you cannot tell which products a certain client is going to pick. So as we move on this, let's have a comprehensive agenda. Let's go big in the communities. If we can try to administer lane in a community model, the use of the RDTs, including the self-test kits as well, will be something which will be highly. For Zambia, the community model is something which we think is going to make a difference, and also using an integrated manner in the rollout of lane. I think with that, just needed again to welcome everyone who has joined in. I think the insights are very important as we again begin another exciting journey around the implementation of injectable PrEP. Thank you so much, Wahira. Over to you.
Thanks, Professor Lloyd, for those remarks. True, we do not have an excuse to make more mistakes. We've learned a lot. We have a platform to share. And so let us continue sharing. Now, I want to hand it over to Patricia to share insights from Kenya. Over to you, Patricia.
Thank you very much, Wawira, for having me here. My name is Patricia Jekonaya. I work with LVCT Health, a local Kenyan organization that has been implementing HIV programs, gender-based violence, mental health, and sexual and reproductive health for over 20 years. So my role is I lead policy advocacy and also HIV technologies introduction at LVCT. Next slide. So I will give the Kenyan story in terms of what we've learned as a country and how we are utilizing these lessons even as we prepare for the rollout of lenacapavir. So we rolled out oral PrEP nationally in 2017 with the government taking lead under NASCOP, and we then established the PrEP Technical Working Group, which continues to support the scale up in the country. To date, we have initiated over 700,000 people on oral PrEP in about 2,500 facilities across the 47 counties. So as a country, we had a target that by 2022, we would have less than 8,000 new infections. But as it is in 2024, we had an estimate of 16,000 new infections that are largely concentrated amongst adolescents and young people. A majority of our PrEP users identify as general population, but we've also learned lessons, and so our current tools have been disaggregated into various subpopulations, including pregnant and breastfeeding women, so that we're able to capture that data. Our persistent challenge in initiation has continued, especially amongst the adolescent girls and young women, and even the effective use. So we have very high drop-offs after month one, very low continuation rates. Our integration has also been quite suboptimal across the various facilities, where the focus has mostly been on providing PrEP through the comprehensive care clinics. And we now have a bit of the integration happening in MCH. There has been very little demand generation going on across the country, and this has already been alluded by previous speakers. HIV stigma is still quite high, and people who are interested in prevention are really being affected by this stigma. We've had issues around the color of the pill, and people just thinking that if you're using PrEP, then you're promiscuous. So as a country, that is something that we need to continue addressing. And then we had the dapivirine vaginal ring approved in Kenya in 2021, but it took us more than 2 years to get it started in the country through an implementation study. We never really got to introduce Kabele. The stop work orders came in January when we were just about to roll it out in the study. And so most of the lessons I'll be sharing are around oral PrEP delivery and also the dapivirine ring, which we had an opportunity to do. And then the PrEP program in the country, generally prevention has been heavily donor funded. So we are getting into a season where countries have to take leadership, and what does that really look like? Next. So I will look at the various components within the value chain, starting with the regulatory approval that has already also been mentioned, and it's very critical that we engage the regulatory bodies quite early for them to understand the products, interact with the data that's coming out of the clinical trials, so that by the time the package is submitted to our countries, then the various stakeholders play their part, civil society and communities advocating for the same, but also having the Ministry of Health, being able to speak out in terms of the interest that these products, have when it comes to eliminating new infections. And then budgeting is very, very critical, and price transparency remains a major barrier. Even as we push for domestic resource allocation, the big question is how much is the product? So that's something that I really hope that as we continue with the conversation around lenacapavir, that as the product developers, it will be very clear so that we know what we are able to afford as countries. The provider training, we also have learned the physical trainings are quite resource intensive. And so there is need to look at other methods, virtual platforms, offline, where people can download the materials and be able to study by themselves, but then also ensuring that there is a very clear and structured ongoing mentorship that takes place to boost the confidence of the providers, and ensuring that all the job aids are available to them. Sustaining demand generation. For most part of our oral PrEP implementation in the country, and even when we had the dapivirine vaginal ring, there hasn't been sufficient resources to do demand generation. And so we need to identify ways in which we can be able to sustain and grow the interest of PrEP. And then also using appropriate channels depending on the populations, diversifying this to go beyond having posters in a facility to using peer-led approaches, community spaces and digital media. The supply chain, this again is one that is very tricky, that given the availability of the commodities, that we must have a very elaborate plan on how we are going to manage the limited supply in terms of focusing on the geographies and also the populations. And I know the key lessons that we learned is once a product comes, and we tend to speak about specific populations that are eligible, then at some point we lose it because the product is then stigmatized even before we start. And so we've learned key lessons there, that we make it available to anyone, that it is at substantial ongoing risk, but of course looking also at the data, which geographies would require this much more than others. Next. And in terms of the service delivery, we really need to move beyond, for us as a country, beyond the comprehensive care clinics to look at other sexual and reproductive health service delivery points where we see more women and girls going to access. And then PrEP choice is key. Counseling to make sure that the providers are giving information and allowing the users to make the decision on which type of PrEP method really fits into their lifestyle. And as their lifestyle evolves, how do they switch in between products? We also need to take advantage of community spaces and also the private sector delivery as a way of a total market approach. And this is one area as a country that we are very keen on, and ensuring that stakeholders are involved quite early. We know the issues that come whenever we introduce new products, and now it's an injectable. We need to start engaging the stakeholders very, very early so that there is understanding and they know how these products work, so that we address the myths and misconceptions as early as possible. Then for the monitoring, evaluation, and learning, we need to include indicators that will help us, to make decisions around the stocks that we need to have, the methods that people are using, and also scaling up our electronic medical records. We've been in a number of facilities, have been very manual, but we are also learning that then delays in terms of the decisions that are being made on a day-to-day basis. And lastly, also defining the implementation research agenda as we roll out the new products. What questions are still pending? Which ones haven't we answered? And how do we then incorporate them so that we have a holistic way of learning across the various PrEP options that are available? I think that's it. Thank you.
Thank you so much, Patricia and Hasina, for sharing those great insights from the country. And now we are going to move over to pop cancer and genesis and analytics, where we'll have Natasha and Kamal take us through what it takes to, support PrEP use in Sub-Saharan Africa. I think we'll be starting with Natasha. Natasha, if you can hear us, over to you.
Good afternoon, everyone. Thank you for joining the webinar. We just had some excellent country perspectives. We want to present this evidence summary on what works to support PrEP adherence in Sub-Saharan Africa. This came out from a direct ask from the countries in the South to South Learning Network. Next slide. Our presentation covers the introduction, objectives of the review, methods, key findings, considerations, and recommendations. So we'll walk through what works to support effective PrEP use. So despite increased availability of PrEP options such as oral PrEP and injectable PrEP, limited uptake and high PrEP discontinuation rates threaten the overall effectiveness of HIV prevention efforts. In 2023, 3.5 million people globally received PrEP at least once, with over 75% of these being from the African region. By the end of 2024, that number rose significantly to 8 million people. However, these numbers are lower than the global target of 10 million people using PrEP by 2025. Adherence is critical as many key populations disengage during high-risk periods, which begs the question on what strategies are truly effective in supporting effective use of PrEP and what are the lessons for the way forward. Next slide, please. Our scoping review aimed to identify effective interventions and implementation strategies to support effective use of PrEP in Sub-Saharan Africa. Our objectives were to identify which interventions improve PrEP adherence, examine how these interventions are implemented, and explore how context influences effectiveness, who is being reached, as well as where the gaps remain. Next slide. So we conducted a scoping review of 40 peer-reviewed articles from PubMed that were published between 2019 and 2025, focusing on PrEP adherence and support in 15 South-to-South Learning Network countries. Next slide. So most of the studies we reviewed focused on oral PrEP and were implemented at either pilot scale or large-scale implementation. And 14 of the studies used a rigorous research design, such as a randomized control trial. And PrEP adherence measures varied across the studies, including drug or pill counts, biomarkers, and self-reported adherence. Next slide. So in terms of the key findings, our review looked at what interventions address adherence barriers at individual level, healthcare and system levels, and community levels. Our review found that individual level interventions, often combined with healthcare interventions, were most successful in improving PrEP adherence. A variety of intervention packages were implemented to support PrEP adherence or effective use. And the graph here shows that shows the number of studies across the various intervention levels. Green represents all studies. The orange highlights the number of interventions that improved PrEP adherence, and the yellow highlights interventions that improved PrEP and also used an objective adherence measure. Interventions with individual PrEP users only were the most tested interventions, followed by multi-level interventions, then individual level interventions, which were combined with healthcare interventions and others. Over half of the studies, around 22 out of the 40, reported an improvement in PrEP adherence. Of these, 10 used objective measures of adherence, such as drug level testing using either blood or urine samples. Using the more objective measures of adherence, the combination of individual level and healthcare interventions seemed to yield the best PrEP adherence outcomes. Next slide. PrEP adherence interventions varied significantly across the SSLN countries, highlighting disparities in tested implementation strategies. Kenya, Uganda, and South Africa had the highest diversity and the highest number of interventions with an improvement in PrEP adherence across all categories of the interventions, that is individual, healthcare, and community, indicating a multifaceted approach to HIV prevention. There's also a general underutilization of community interventions across most countries, with only Kenya, South Africa, and Uganda showing notable use. Next slide. Successful individual level interventions address education on effective use of the PrEP method, personalized counseling, risk assessment, and personal readiness. So 40% of the individual level interventions put emphasis on personal agency and developing a trusted relationship with the healthcare provider. 27% provided education to address personal concerns and support users to make informed, proactive decisions about their health. 17% implemented technological approaches such as providing timely prompts and reminders. However, users face structural barriers like network challenges or challenges around access to electricity, access to smartphones, as well as just a general SMS fatigue. Next slide. An example of an individual level intervention that improved PrEP adherence is the interventions for HIV prevention among adolescents and young women, which was abbreviated as the IPAD study. In this study, effective education, counseling, support tools, and incentives were facilitators for PrEP adherence among high-risk adolescent girls and young women in Uganda. So adolescent girls and young women who reported having transactional sex were recruited from bars, lodges, and urban slums and were enrolled in the IPAD study that was based at a clinic in Kampala. So adherence was measured by one-time blood samples, pill counts, as well as self-reports. The intervention components included group education, adherence counseling from healthcare workers, support tools or devices such as phones, alarm clocks, and watches, and incentives such as transport or sanitary pads, as well as free reproductive health services. Next slide. Successful healthcare interventions address healthcare provider knowledge as well as biases. They also include non-traditional providers in PrEP delivery and improve access by providing targeted services and integrating PrEP into existing services. Effective healthcare provider interventions also include training in PrEP eligibility and clinical management, increased provider knowledge of PrEP options and stigma reduction activities, while effective health system interventions include key population and youth-friendly clinics and integration of PrEP into existing SRH services or other routine care and also just increasing the number of access points for PrEP, such as mobile clinics, telehealth, or pharmacies. Next slide. The Partners Scale-Up project in Kenya provides a helpful example of a successful PrEP integration program. In this study, PrEP was integrated into 25 high-volume public HIV care clinics in Kenya. Women and men aged 18 plus were offered daily oral PrEP. Healthcare providers were trained on PrEP delivery, and health facilities also made modifications to their existing HIV care programs to improve access and facilitate PrEP integration. In this study, technical support and training provided to the healthcare providers was associated with increased PrEP service delivery and improved adherence in the 25 participating clinics. Next slide. For community-level interventions, our review found that successful community-level interventions address PrEP-related stigma, negative social norms around sexual practices, and they also foster supportive environments for PrEP use. Effective community interventions incorporated community leader engagement and mobilization, community-wide PrEP education campaigns, peer-led outreach and support and stigma reduction campaigns. The DREAMS program in Kenya provides a good example of community-level interventions. The intervention included meetings with local chiefs and parents to build support, male change agents-led sensitization events for male partners, and they also had what they called buddy days, where couples were engaged in safe spaces and routine health services were offered to reduce stigma. However, the evidence shows that community-level efforts alone are not sufficient. Studies with improved adherence consistently combined community-level interventions with individual-level support, suggesting that community engagement must be paired with direct user support to be effective. So I'll pause here and I'll now hand over to my colleague Kamo for the rest of the presentation. Thank you.
Thank you very much, Natasha. Next slide, please. So just following what Natasha has shared, although most of the studies were from oral PrEP, a lot of the learnings can be applied to the rollout of newer products, as mentioned before, like LEN. But what I wanted to emphasize, based on the evidence, we now know that a one-size-fits-all approach to PrEP adherence is insufficient. Interventions must be tailored to the unique needs and behaviors and social realities of these specific populations. Next slide, please. So here we can see that the evidence says all of these things for the different populations. For AGYW, it's important to address their dynamic HIV risk perception, their high mobility, and their anticipated stigma. And here it's important to consider counseling that address fluctuating risk and guides them on rational PrEP use, supplemented with community support. For MSM and LGBTQI+ individuals, they have persistent societal stigma and judgmental health services as major barriers. And here it's important that we consider an approach that prioritizes choice-based delivery models and includes long-acting PrEP, but also considering alternative delivery methods that are also discreet and affirming care supported by peer-led models. For ABM, they have a low perceived HIV risk and a transient lifestyle. And here interventions should include targeted PrEP education, mobile delivery options, as well as partner support. For FSW, they have multiple prevention needs and they often face low community awareness of PrEP and judgmental health services. Here it's important that we consider tailored multi-level support to address these multiple needs that they have, along with sensitizing healthcare service providers. And lastly, we have PWIDs. Here we found there was very little evidence and insight, but we do know that they face multiple health needs, social stigma, and legal barrier as challenges. And here we should try and consider discreet and confidential care in community-based settings. Next slide, please. Again, based on the evidence, effective use of PrEP depends on social, structural, and policy contexts within which HIV prevention or PrEP is being offered. So having a look at these three contexts, first we have social-cultural and socio-economic contexts. Here, barriers include the fear of being labeled as sexually promiscuous, the fear of being seen as HIV positive, and the challenge of competing needs like health versus economic survival. Secondly, we have health system characteristics, and here we see issues where a lack of trained providers for PrEP services, provider attitudes towards PrEP, and a lack of infrastructure to monitor the effective use serves as barriers here. And lastly, for policy and program environments, this includes restrictive guidelines that limit who can administer PrEP and inflexibility in a provider's ability to make innovative adaptations to the delivery. Next slide, please. So lastly, before we move on to the recommendations, we wanted to share this framework that's been adapted from earlier work that was used to guide the introduction of oral PrEP among AGYW. The framework has two sides. On the right side, we focus on main factors that determine the feasibility of effective provision of quality PrEP services. Here, the factors include scientific context, political landscape, health system infrastructure, and provider dynamics. For instance, operational guidelines that only permit certain healthcare providers to administer PrEP can have major implications for product access. Service providers are closer to the center, and here we can see that they're the gatekeepers to new medical products, and their knowledge, attitudes, and perceptions will determine whether and how they offer which PrEP method to different populations. But on the left side, we then focus on the factors that determine whether individuals are able to make informed decisions around their PrEP options. Here, the key factors are community context, family dynamics, partner dynamics, and an individual's own characteristics. For instance, broader community level knowledge about PrEP, but experiencing violence in a sexual relationship are likely to influence a person's decision about which PrEP option that they would choose. Further, people's access to education, perceptions, and different PrEP options and social support and their own HIV risk perceptions are likely to significantly influence their PrEP use. So this framework basically shows us that individuals and service providers are really at the center of this dynamic, and it's important that we consider this interplay as we need to fully understand how to have effective PrEP provision for these populations. Next slide, please. So lastly, we've gathered some recommendations for PrEP policies, programs, and evidence generation. Next slide, please. So for program recommendations, it's important to prioritize a user-centered design and choice-based counseling. Here, we should aim to strengthen provider support and make use of basic digital tools. It's important that we empower choice by offering choice-based counseling, offering tailored adherence support by training providers for brief or repeated counseling sessions to address the ever-evolving needs of these different populations. It's important that we reduce the logistical burdens by considering using mobile delivery or a multi-month dispensing mechanism. We should normalize PrEP by trying to embed it into the non-HIV care interactions as well. And lastly, as I highlighted before, using simple technology, such as leveraging SMSs or phone calls or other tech that is accessible. Next slide, please. Policy recommendations, it's important that we prioritize integration, decentralization, and a simplified support protocol. And here, these 5 aspects highlight that it's important that we leverage existing platforms and infrastructure by trying to integrate PrEP services and adherence support into the national HIV and SRH services, by decentralizing PrEP delivery, trying to also make use of community-based sites, DICs, and community health worker-led outreach. We should also try and standardize support by adopting a minimum adherence support package in national guidelines. Also trying to expand PrEP delivery beyond the other healthcare providers by making use of pharmacists and community health care workers. And lastly, promoting regional learning as we're doing here through SSLN and i2i or other regional networks to develop technical guidance and share tools and lessons across countries. Next slide, please. And lastly, as we consider evidence generation, it's important that we try and fill gaps in knowledge and evaluate the new service delivery models. We should try and build in monitoring and evaluation into PrEP programs so that we can assess the effectiveness of the PrEP programs. We should be evaluating long-acting PrEP options as well by studying the uptake, the effective use, and acceptability across these populations. We should aim to strengthen qualitative insights as well by exploring the enablers and barriers like personal agency, or stigma, or provider attitudes. We should also look at assessing task-shifting models by comparing the cost-effectiveness and outcomes of non-traditional provider-led programs. And lastly, we should try and standardize adherence measurements. And we've seen in these studies that inconsistencies in adherence measurement, such as self-reporting versus biomarkers, really limits the comparability, and it will be helpful to try and standardize these. Next slide. Lastly, I'd just like to acknowledge the i2i team for working on this evidence summary, and hopefully some of these insights will inform some of the participants online as they consider the rollout of newer products, but also taking on the lessons that can be learned in the face of the funding landscape that we find ourselves in. Thank you so much.
Thank you so much, Kamo and Natasha, for those beautiful insights from the review. And thank you everyone else for the great, learnings. So many learnings, such rich insights and tools to draw from, even as we prepare to, launch new products and advance the ones that we have. Now we do have an opportunity to respond to some of the questions, and thank you all for sharing the questions that you have on the chat. Please continue sharing those. But I did want to kick us off, and we'll be getting down. Some of those have been addressed, and I'll try and see whether we have different contexts or responses from other presenters. But I would love to kick us off by asking Kat a question. And Kat, the assessment that you presented earlier, the study that you did was done pre the January, issues. And I wanted to understand from you, given the, events of January, how does this affect your findings and recommendations? And then trickling down to the countries where we were giving recommendations, how applicable are these recommendations given the new reality? We have so much to do with so much less. How do we manage that? And then I'll as you answer that, then I'll line up a couple of questions for the presenters. Thank you.
Thank you so much, Weira. That's a great question. So we have been tracking the impact of these PEPFAR stop work orders on a lot of programs, and I'll put a link in the chat in a moment. But some of the big things we're seeing, first of all, key populations massively affected. A lot of key population programs were funded by PEPFAR, and those have all been cut. Also, new product introduction, another big one that's been impacted. We know that PEPFAR had been planning to roll out injectable CAB for PrEP to around 100,000 people this year. We think that's now going to be more like 5,000 people. So huge impacts on new product introduction, which also impacts our ability to learn from new products and apply them to other ones. We also saw huge impacts on human resources for health. Lots of providers who were made redundant or furloughed. Some can still continue to work even though they weren't being paid, which is quite amazing. But places that were already quite stretched became even more stretched. And of course, we need to ensure that treatment programs continue as well, which means hard decisions for governments.
Thank you so much, Kat. And so I'm going to ask a couple of questions to the presenters and to Asina. And I know Kat trying to answer this question, but there was a question in terms of how the 1 month persistence was assessed. That is to Asina. And then to all the countries, I think there was a question in regards to any evidence on PrEP uptake amongst PWIDs, especially among the female subgroup, any information on HIV epidemiology data amongst this group, and lastly, how delay in regulatory approval and supply chain can be mitigated. And I know Patricia tried to address some of that, and unfortunately, Kenya was one of a case, waiting over a year to get approval for CAB. So if the presenters could speak to that, and maybe we can start with Asina.
Thank you, Warira. So I'm going to try and answer some of the questions that you raised. And the one is around the supply chain. And I think one of the things that we really need to get right, and this was the supply chain issues were interestingly not by the countries. It was by the product developers and the distributors that had the challenge. So we really do need to make sure that upfront that the product developers understand the supply route within countries, because each country, the supply route is quite different. And we need to make sure that that doesn't become a bottleneck for availability of supplies. The second question that was around the 1 month versus the 3-month persistence. These were the studies that had assessed and the studies that were implementing PrEP in those different 87 sites that we identified. They were implementation science studies. So they were very closely monitored, and individuals were tracked using a cohort tracker. And when they returned for their visits, were recorded for each of the different time periods, whether it was 1 month or 3 months. Also, clients were called during that time or contacted to see why they didn't want to continue with their particular product that they were initiated on. And that also gave further insights as to sort of whether people stopped because they were no longer requiring the product, or they were no longer interested, or they were just, basically just lost. So I think those were some of the insights that we got from the studies. But, the study reports do provide a more detailed deep dive into the persistence rates. And then I want to address the questions raised by Ali around the issue of restricting availability of particular products. And I think one of the things that we have to think about quite carefully, that initially, oral PrEP, we had a very, very small supply of oral PrEP. If I recall, we only had sufficient to start with 17 sites, and we only implemented it for specific populations, and we expanded as we went along. Right now, oral PrEP in South Africa is available to anybody that requires it. So there is no restriction. It's not for particular populations. And yes, demand creation and HIV testing is accelerated amongst those populations that require and will benefit most from PrEP, as well as in geographic areas. But it does not mean that in areas where there is low HIV incidence or where there's low demand, that this is not being implemented. Everybody gets it. When we look at the new product, which is LEN, we are going to get a very restricted supply. And, we are one of the 9 early adopter countries. And yes, we did get the lion's share compared to all of the other countries, but even that is very, very limited in terms of who we can reach with lenacapavir. And given the limited supply, we need to think about how we're going to distribute it and make sure that those that would most benefit from lenacapavir access it at the beginning. So we're not saying that it will be forever. It will be as we start, we need to start in those areas. But also coming back to the issue of looking at where we've had the greatest impact of the USAID stop orders, we also need to make sure that we don't put in lenacapavir in areas where delivery is going to be impacted by these work stop orders, so that we have products sitting on shelves and it's not being delivered. So all of these are taken into consideration with the implementation of the new lenacapavir products that we're getting through our limited supply from Global Fund. Thank you.
Thank you so much, Asina. I think you've covered quite some ground in terms of the questions that were directed to you. And I wanted to find out whether there's anyone that is able to respond to the question in regards to the evidence that we might have on PrEP uptake amongst the people who inject drugs, especially among the female subgroup. Anyone?
Wawira, I may just make a comment over our
Yes,
experience in Zambia over that subpopulation.
Okay.
Whereas majority of the people that we have, the AGYWs, and also the MSMs with an intersectionality, the uptake for those who inject drugs, specifically, I do not have the data for the female population, but the uptake has relatively been quite good. I think around 60% of those that come for PrEP. This is when now we are trying to establish just centers for where we are administering methadone as well as MAT clinics, and then we may be able to collect better data. But so far, we have not seen any major difference in terms of uptake. But for the gender based on that subpopulation, we don't have that data. Of course, it's an area which we need to learn in much, especially with maybe any possible interactions as well. But we are not going to segregate and also use that as a window not to provide any lane so far. Thank you.
Thank you so much, Prof. Then I know Patricia responded in regards to training of the community health promoters to provide subcutaneous LEN. And I wanted to find out whether, Prof, again from you, I know that one of your key delivery channels that you're thinking about is through the community channels, whether how you're approaching that. And then to all of you, there's a question in regards to the sustainability of providing incentives. How sustainable is that? Is anyone of you using that model? And what is your plan in regards to that?
So for the community channels, we are trying to use the community health workers who have been providing DMPA for family planning, but also we are deliberately planning to recruit some of the community health workers from these risk subpopulations, so that when we recruit them, and it's coming at a time, LEN possibly will come at a time when we are going into a drive to recruit about 20,000 community health workers or community-based volunteers as well. So we deliberately want to include some of these subpopulations, and once we include them and we train them, then these will be the ones that we may need now to utilize for administration of LEN, but also intensive training around counseling, around HIV testing. We think that may be a more sustainable model for us if we use these CBVs. And then the issue of incentives, it's not something which we are trying to encourage. For Zambia, we want to build on sustainable systems, which even if a donor withdrew, that should be something we should be able to take up. So the incentivizing is something we are really trying to run away from. That is for Zambia. Thank you.
Thanks, Prof. And maybe lastly, in terms of the questions, I can't see any more from the team. And there's a question around a precision that LEN is highly effective, but also it is expensive in terms of the cost. So how do we ensure that we reach people at the highest risk of infection? And please, Prof and Patricia, feel free to respond to that. I know Asina had touched on that.
So if I can just share the thoughts that we are having at national level as we plan for LEN is really going back to the data, the evidence. We are looking at which geographies do we have high incidence amongst which particular populations. So you might find like in a big geography, say if I look at Nairobi, we are not seeing new infections everywhere in Nairobi. There are pockets in Nairobi where we have identified the new infections there. We have the specific populations that are there. And so in terms of targeting with the limited products, we want to go where we feel there will be high impact at the beginning. And then as more of the products come, we have lined up a very clear phased out approach where we cover the areas that we are seeing new infections as we continue to add on additional areas. So given the limitation with the product, the cost of the product, we really have to be targeted in terms of looking at our data and making decisions using data.
Thank you so much, Pat. I know we still have so much to cover, so many questions. Feel free to send them.
Wawira, if I may add just one caution to that approach. That is the approach which we used in Zambia for rolling out of CAB. And we thought that, of course, we're going to have a lot of people move from oral PrEP, go on to CAB, and we're going to have a lot of people also enroll in. I think the danger is if we really just concentrate on certain subpopulations, we may lose out. Over 16 months, that's when we've just surpassed the 4,000 mark. So I think it should be a balance in terms of uptake versus the subpopulations. Otherwise, with the targets like for Zambia, where we need to reach about 20,000, if we went through that approach, we are not going to reach there. I think we need to invest heavily in demand generation, but also we need to know that there are certain subpopulations which may not identify themselves as being in those categories. I think it's just important to look at where is the incidence high, but let's loosely allow a lot of people to come through to access, or else we are not going to reach the numbers and we are not going to reach really the target which we need for us to reduce HIV epidemic in terms of incidence. I think it should be a balance, and we need to be very clear so that we don't miss out on some of the populations who may not identify themselves as such. Thank you.
Thank you so much, Prof, for those sentiments. And, yes, we need to balance. And now I want to thank everyone. I would love to hand it over back to Lucy Maikweki to take us through the last emotions of this meeting. Over to you, Lucy.
Yeah, thank you, Wawira, and want to appreciate all our presenters for the excellent presentations. Before I make the closing remarks, I just wanted to highlight, I'm hoping that you can hear me. I just wanted to highlight about the LEN PrEP standard operating procedure that we have come up with. You can move to the next slide. Yes, thank you. So following the release of the WHO recommendations on LEN PrEP, SSLN, i2i, together with input and review from the Global Fund, CHAI, and WITS, RHI have developed an SOP for LEN PrEP just to make it easier for countries to adopt the WHO recommendations. So the SOP is designed as a template to be able to support quick development and adoption and ensure that the national SOPs are aligning with the WHO recommendations. The SOP can also be adapted for the countries that do not already have national guidelines on LEN PrEP, or the SOP can be adapted as that, or even as a policy addendum. Next. So the SOP has been developed, or the content from the SOP has been sourced from various documents, including the just recently announced recommendations from WHO, the guidelines on LEN PrEP, the WHO and JPIGO provider training toolkit, as well as other documents. They have been used to develop the SOP. And what can you expect to find when you get the SOP? So we have the product information, we have PrEP initiation. What do you need to do for PrEP initiation? The HIV testing, assessments, PrEP counseling, PrEP prescription. What do you need to do for follow-up visits? And most important, management of clients in specific situations. For example, seroconversion, side effects, how do you deal with those? Adverse drug reactions, how do you deal with those? And then pregnancy and breastfeeding for LEN PrEP. Then who can disseminate, or who can provide LEN PrEP services? So that's what you can expect to find in the SOP. And just to highlight, when we say that it is a template, what does this mean? So there are two aspects. You will find areas that are in red font, and these are areas that you will require to include national updates. Then you will find segments that are in green boxes. This is content for consideration by countries. So you can review the considerations, maybe informed by regulatory bodies, availability of product information, or just country level insights. And once you've agreed on those, you can either update the green boxes or you can totally do away with them. So those are the two ways that you can use the PrEP SOP as a template. And this is already available. Next. This is available on the SSLN website. The SSLN and i2i website is a Microsoft document for ease of adaptation. We also have a PDF document included. Over and beyond that, we are welcoming queries and comments, and those can be sent to the info@i2i@genesis-analytics.com. So any comments, any feedback that you have related to the SOP, you can email them to us and we'll be able to address them. Other resources that are on our website are the e-training course for PrEP that includes LEN, and this is the recently recommended WHO JPIGO toolkit. So these are the resources that you can find on our website that will be able to support you as you adapt or as you roll out LEN PrEP in your countries. Next. Thank you. So just a summary, I want to appreciate all our presenters. A lot has been said in this journey as we seek to increase the momentum on ARV-based prevention. Several things have come out as factors for consideration if we are to be successful in increasing the momentum. And this include the regulatory matters around regulatory issues, the need to include or contact the various stakeholders so that you ensure that you address any barriers beforehand. And I think something else that has come out critical is also working with the manufacturers, especially when you're talking about the supply chain, manufacturers understanding what is required within the supply chain in country, what is the route to market for the product. In terms of planning and coordination, things that need to be considered, cost versus effectiveness. So LEN PrEP is a very effective tool, a very effective product, but in terms of the cost, it may be a bit high. So those are some of the things countries need to consider. Involvement of key stakeholders, including the communities, that has come out very clearly. We should not leave out the communities, include the communities early on so that we are planning and coordinating with them. In terms of service delivery, things that have come out are around integration. How do we integrate LEN PrEP as well as other PrEP methods within other service delivery aspects in the health facilities? What does differentiated service delivery look like? And what do we need to do? Because in the era of reduced funding, how do we address policy barriers so that we are ensuring that the product is getting to those that need it in the best way possible. Training of healthcare workers, especially on counseling for choice. I think that's something that has come out very critical. In terms of the supply chain, again, as I've said, working with the product developers to understand the supply and route to market. Something else that has come out as very critical is demand generation. I think we have had a lot of product introduction with very little resources set apart for demand generation. So demand generation resources, we need to consider those alongside service delivery and introduction of product. And then what does demand generation for choice look like? So those are some of the things that we need to consider. For monitoring and evaluation, how do we leverage existing data? How do we update our M&E systems so that we include not just LEN-PrEP, but any other products that may be coming in? So in summary, those are some of the things that we need to consider as we seek to increase the momentum on ARV-based prevention. Our presenters have been kind to share resources and links, and we'll be able to share the presentations after this. We'll be able to share all the presentations as well as the links on the chat. Remember to look out for the WHO webinars that will be coming up in the next month. There's the new guidelines on LEN-PrEP. There is HIV testing together in partnership with PSI, and there's the e-training for PrEP. So look out for these webinars as we continue to learn on how we can be able to scale up and really increase the momentum on ARV-based prevention. So that is it for today. Thank you so much to all our presenters, to all our participants. This webinar would not have been successful without you coming on board, asking all the questions that help everybody to think through everything. I want to thank AVAC, SSLN, and i2i. And of course, last but not least, the team from SSLN and i2i and AVAC that has been behind the scenes putting this together, ensuring that the system stayed up and working, and of course to our translators. Thank you so much, everyone, for joining. Remember to look out for the WHO webinars, and we will be sharing these presentations after this. Thank you so much, everyone.